Welcome to Pomegranate Health and the first case report of 2026. I'm Mick Cavazzini for the Royal Australasian College of Physicians, but the episode itself will be hosted by Associate Professor Stephen Bacchi. If you're new to these case reports, they're told from the perspective of a physician who was involved in the case management. Dr. Bacchi prompts our guest to walk through the case in a way that a trainee might during a clinical case presentation. But please bear in mind that this is a passion project, not a vetted or verified exam resource. Please double check on any clinical details you find interesting. The article discussed today was published in 2020 in IHJ Cardiovascular Case Reports Volume 4, but I won't give any spoilers just yet. Just imagine being presented with a 75-year-old man who has severe aortic stenosis but is deemed unsuitable for surgery on the basis of a porcelain aorta. The patient had, a decade earlier, been diagnosed with hypertrophic cardiomyopathy after presenting with syncope secondary to ventricular tachycardia. This was associated with a host of comorbidities, and a dual-chamber ICD was implanted at the time for secondary prevention. The patient is now being considered for staged alcohol septal ablation for the HCM and transcatheter aortic valve replacement for the stenosis. However, additional complications force some out-of-the-box thinking. Here's Dr. Stephen Bacchi with the rest of the introductions.
Hi, I'm Stephen. I'm a neurologist in the Northern Adelaide Local Health Network, and today with us we have Prof. Roberts-Thomson, who is an academic cardiologist at the Central Adelaide Local Health Network with a particular interest in valvular heart disease, and Dr. Alistair Leslie, who's a cardiology registrar at the Central Adelaide Local Health Network with interests in digital health and artificial intelligence. Thank you both for joining us.
Thank you, Stephen.
Thank you, Stephen.
So as usual, we'll be discussing a previously published case report in a step-by-step manner with a focus on content that's relevant to trainees and a generalist audience. But today we're going to take a slightly different route. So we're going to jump in at the end and then explain the context for the patient's presentation. So we have a 75-year-old male who is being considered for a transcatheter aortic valve replacement, or TAVR, and alcohol septal ablation, ASA, for severe, heavily calcified aortic stenosis and hypertrophic cardiomyopathy, or HCM. He's been classified as inoperable by the cardiothoracic surgeons. He's a dual-chamber ICD for secondary prevention, and he currently has NYHA Class 4 symptoms. So Prof. Roberts-Thomson, there's a lot to unpack here. Let's start with the HCM. So for basic physician trainees who are in the process of sitting their exams, what do you think is important for them to know about HCM?
Well, I think there's a few things about HOCM, or hypertrophic obstructive cardiomyopathy, that are really important. One, it's a dynamic obstruction. So rather than aortic stenosis, which is a fixed obstruction, this can increase and decrease depending on volume status, rhythm, rate, and it's really important that a single echocardiogram may under or overestimate the severity of HOCM. One of the key elements with hypertrophic obstructive cardiomyopathy is that you get thickening of the basal septum. This encroaches on the LVOT, and then you get high velocities through that LVOT. And it's not only that high velocities from that obstruction that cause the issue, it's also then you have movement of the anterior leaflet of the mitral valve towards the outflow tract, further narrowing the outflow tract, and that's called SAM, and that's systolic anterior motion of the mitral leaflet. So these are a really important concept, that it's a dynamic process, and when you diagnose it, it's diagnosed on echocardiography for HCM, and you can see both the increase in the septal thickness, the increase in flow velocities prior to the aortic valve, as well as movement of the mitral chordae, called caudal SAM, or anterior mitral leaflet, called SAM. So those are the things that we can diagnose on echocardiography. And similar to aortic stenosis, the severity gradings are similar. So mean gradient or velocities greater than 40 or 4 respectively end up that being a severe obstruction of the outflow tract.
Thank you for that overview. Now, aortic stenosis is another key condition for BPTs. Could you please similarly walk us through an overview of this condition, and particularly the relevant content that's maybe missed by BPTs as a part of their physical exam and echocardiogram findings in the clinical component of the exam?
Yeah, so similarly, so aortic stenosis is a fixed outflow obstruction. So generally, depending on echo to echo, it isn't as dynamic and doesn't change as much. So what you see is a gradual progression of the severity on echocardiography. So from a patient perspective, the number one symptom would be breathlessness. You also have the non-specific symptoms of fatigue as well, which has been increasingly recognised. In the more severe cases, you can get angina, and most worryingly, pre-syncope or syncope on exertion, which can also happen in both HOCM and in aortic stenosis, and they're probably pathognomonic of severe or critical outflow tract obstruction from any of those conditions. Now, on clinical examination, there's a couple of really important findings. Everyone gets very focused on the murmur, and in the clinical exams, everyone wants to tell me all about the murmur. But as of anything in a cardiology exam, the most important thing is the peripheral findings are the most important in terms of diagnosing the severity of the cardiac findings. So in aortic stenosis, you can have a narrow pulse pressure, which is a good peripheral finding. You have a soft A2, so you can have a soft second heart sound. That's often a very good finding. You have a slow rising pulse at the carotid. And what else do we get? You get a number of other things. So in terms of the murmur, it's a crescendo, sometimes crescendo, decrescendo, but most importantly, when you get moderate or severe, it ends up being basically a crescendo murmur that you get. There's a couple of other findings that I've forgotten at the moment, but essentially most of them, in terms of the findings from physical examination, if you have a slow rising pulse at the carotid, if you have narrow pulse pressure, you've basically, before you've started to look at the exam, said this is going to be something significant. So in terms of severity, this is going to be a moderate or severe valve finding, because you get finding all these signs peripherally. In terms of echocardiography findings, often calcific. If people are under the age of 60, you've got bicuspid aortic stenosis. The association with dilation of the ascending aorta and aortopathy is also there as well. So things to talk about in your exam is not only if it's a young person with aortic stenosis, but is this congenital? It's our most common congenital cardiac condition is bicuspid aortic stenosis, and commonly associated with aortopathy. So making sure you look and examine the size of the aorta on both echo and CT is really important for pre-surgical planning. Echocardiography findings that are really important. So the calcium, you've got whether it's bicuspid or non-bicuspid, and more for younger Aboriginal patients, you can also get rheumatic aortic stenosis characterized by leaflet tip thickening of the aortic cusps. So the aortic valve does not have leaflets, it has cusps, which is a key thing. It's tricuspid there. As before, a mean gradient 10 to 20 is mild, 20 to 40 is moderate, and a mean gradient above 40 is severe. Be careful for those who have high circulatory conditions such as dialysis, where they have a fistula, and so they have a high cardiac output, because that can overestimate aortic stenosis. And also consider those with LV dysfunction or the elderly who have a poor ejection fraction, in which case the mean gradient may be in the 20s or 30s, but actually be severe because the ejection fraction isn't strong enough to create that high gradient. So it's called low flow, low gradient, severe aortic stenosis.
Great, thank you. So now we've got a clear understanding of both HCM and aortic stenosis. But this patient was deemed inoperable due to a porcelain aorta, and I can't remember this term coming up specifically in my BPT exam revision. Could you tell us a bit about how this determination is made? What does a porcelain aorta mean and how it influences management?
Yeah, so when the cardiothoracic surgeon put people on bypass, they have to cannulate the ascending aorta, and they clamp the ascending aorta to make sure that when they cut the aorta just above the valve to replace the aortic valve, they've got to cannulate it, and then they've got to clamp it. In some patients with severe calcification of the ascending aorta, they are unable to clamp it, or clamping would create significant damage to the aorta. So it means that surgery becomes prohibitive because of the aorta itself. The problem with the aorta from a surgical perspective is when you're doing surgery, you've also got to manipulate the heart. So not only do you have to clamp it, you've then got to open it and then visualize the valve. So calcification lower down also means that it's not pliable enough for the surgeon to open up and get the valve in. So all of these things become basically conditions of inoperability. There are a couple of them. Mantle cell radiation used to be the big one, where they used to basically irradiate the whole chest, and that used to cause significant fibrosis, making surgery very difficult. Porcelain aorta being another one from a technical perspective, unable to put them on bypass and clamp that aorta. And also some sort of chemotherapies can cause significant inflammation of pleura, also causing surgery to be extremely high risk. Now, this is all a spectrum, and depending on the person, it's high risk, prohibitive risk, and the way to determine porcelain aorta is typically by a non-contrast CT is the best way to determine that.
Thank you. We won't go into too much detail, but one of the reasons this patient ended up in this position was because he had a hepatocellular carcinoma identified during the TAVR workup, which required surgical management. Otherwise, his past medical history includes type 2 diabetes, hypertension, hyperlipidemia, and gout. Clearly, the TAVR workup identified a significant pathology, and I know it's a robust process. Could you please outline the process that goes into considering a patient for TAVR and the workup prior to TAVR?
Yes, so the workup is for all private groups, and thus we've sort of adopted it in public around Australia as well, is it's pretty much legislated. You need to have a review by a non-interventionalist, and that could be a imaging cardiologist. You need a review by a non-cardiologist, and that could be a perioperative physician, an anesthesia with perioperative skills or management training. And then depending on the age, the surgical risk, because it's not about necessarily workup for TAVR, it's about workup for the aortic valve, and it's making sure that the right patient gets the right kind of treatment, or that patients don't get treatment if the treatment is not going to be helping them in the long term. So that's our main issue. And if you're over the age of 75, generally the idea is to lean towards TAVR according to the guidelines. If you're under the age of 75, the thought is you're going to lean towards surgery, because the life expectancy of the patients under 75 in general mean that it's potential that you may need a valve-in-valve procedure in the future. So the idea is you put a surgical valve in first, followed by a TAVR, because that is the safest way to do things for the majority of patients. And that's understanding that there are extremely good 78-year-olds and there are terrible 71-year-olds. And so there is that clinical decision-making. And for us, you come into our clinic, we do frailty assessments. So we look at frailty. Some people do grip strength, some people do chair raises, some people do a get up and go test, but we do lots of frailty assessments, check hemoglobin, albumin, and that's the Essential Frailty Toolkit score is the primary way in which around Australia we assess frailty, and it's part of our registries. So we have a frailty assessment. We have an assessment for comorbidities. We have an assessment to make sure all organs are intact, kidneys, livers. We do cognitive assessments as part of our frailty. So we find out a lot of early dementia signs in these patients and refer quite a bit to geriatrics and the memory units. In addition to that, once you've been deemed from a perspective of the patient's sort of comorbidities, are they strong enough and have a comorbid enough that they're going to live for 2 years if you remove the risk of their aortic valve? So there's nothing else that's going to kill them within the next 2 years. Then we need to make sure that they're okay from a technical perspective. So this then looks from a technical perspective. Are the gradients, is it severe aortic stenosis, or is it HCM, or is it something else that we need to be looking at? So making sure that diagnosis is correct. And secondly, we do what's called a CT TAVI. Now, this is a spiral contrast CT dedicated around the heart, which is ECG gated. We look at lots of different phases, and primarily we look at the annulus at the size when the valve's open. So that's used for our valve sizing. Things that can mean that we can't do a TAVI from a technical perspective are that the coronary arteries are low, which means putting the TAVI in, because understanding that we don't take out the cusps like a surgeon would. We don't resect anything, we just push them to the side. If the coronary arteries are low enough that putting the valve in will push the cusps to cover the coronary arteries and cause a heart attack, that's an absolute contraindication for a TAVI procedure. So we can't do it in those cases from a technical perspective. Making sure that the valve size is the size that we have, because there are patients who have too small a valve or patients who have too big a valve. And there are patients who can't have a TAVI because they've got a large boulder of calcium that protrudes into the annulus. So if you blow up a balloon, that boulder of calcium will go outside of the aorta and cause what we call an annular rupture, which is essentially extraordinarily high mortality unless you can get surgery in there quickly. So that's around the valve. And then around the other side is you've got the access, because TAVI valves are quite big even when they're crimped, because we blow them up with a balloon. They go in through the groin and they require roughly at least 6 millimeters from the femoral artery all the way around up into the annulus. So you need to make sure you've got enough capacity throughout that, and that's not too tortuous or too calcified. So our access to put the TAVI valve in is also going to be good. So that's all the elements, but you could essentially say we look at comorbidities and are they going to live, which includes frailty as a comorbidity. We look at are they symptomatic and what is the reason for it, and we look at is it technically suitable. They're the sort of three broad areas that we look at.
Thank you, that was fascinating. So in this case, for this patient, they had an echocardiogram demonstrating a mean aortic gradient of 40 millimeters of mercury and a maximum velocity of 4.1 meters per second. The left ventricle had asymmetrical hypertrophy, including a septal thickness of 15 millimeters. The LVEF was hyperdynamic at 79%. Coronary angiography did not reveal any severe coronary artery disease, and as planned in a single sitting, he underwent transcatheter alcohol septal ablation and then TAVR. So Prof. Roberts-Thomson, clearly this is a significant undertaking. How often has this occurred together? What's the broader significance of being able to combine procedures such as these?
So we've done a few of these, and they're very difficult when you actually have both of them, because when you look at the mean gradient, the question for me is the mean gradient's 40. Is that across the valve or is it across the LVOT? Because you fix one, you might not fix the other. And the problem with HOCM being a dynamic LVOT obstruction versus aortic valve stenosis not being is you can increase the post-LVOT capacity. So you can put in a TAVI, and if you've got HOCM and aortic stenosis, and they're both significant, what you do is you reduce the resistance after the LVOT obstruction, which actually worsens the LVOT obstruction because you're reducing the afterload. So you're reducing the afterload, and so what you can do is, if in this patient you ended up putting in a TAVI valve first, the question for me is there's a condition called a suicide ventricle, and that happens in HOCM and severe aortic stenosis, and that's when you put the aortic valve in, the HOCM gets worse, and it's a dynamic issue. You drop the afterload, there is movement essentially across the LVOT from the septum, and they spiral. So they can crash on the table, and it's called a suicide ventricle, very well known issue. And the thing about it, it actually occurs not insignificantly, because when you have aortic stenosis, you often get a hypertrophied ventricle because the ventricle needs to work harder to get the blood out of the ventricle into the aorta around the rest of the body. And if that hypertrophy occurs asymmetrically, it can be a big issue. Now, you can also test, because there's two types of HOCM in terms of the pathology. There is those who develop because they get long-standing hypertrophy that is not genetically driven, but it's often by aortic stenosis or hypertension. And then there's genetically driven HOCM as well. So if that runs in family, so for all HOCM patients, we often do genetic testings via a genetic counsellor to make sure that we're excluding those in families and seeing if families need screening as well. But for this, it's actually more common than you think. And if the gradient is 40 across the summation of both of those, HOCM and aortic stenosis, my question is which one is worse? But if you're going to do both, which it sounds like you need to, you actually go and do an alcohol septal ablation first to put alcohol down the septal artery that supplies the myocardium that is encroaching into the LVOT to essentially cause an infarct of that area. And then you can do it the same procedure or the following procedure. Then you go and put in the aortic valve. To do it the other way around, the patient may die on the table. It's called a suicide ventricle.
Wow, that's fascinating. In this case, the early postoperative course was uneventful, and at clinic follow-up, the functional status was New York Heart Association Class 1. There was improvement in several parameters, including the mean aortic valve grading to 16 millimeters in mercury, a 12 millimeter septal thickness, and an LV ejection fraction of 65%. A great outcome. To wrap up this case for the listeners, could you please outline a couple of key learning points or take-home messages that trainees could take away from this case and the discussion?
Yeah, there's a few things. One is, and we haven't touched on it, but talking about afterload and blood pressure and preload as well, is if you get into trouble with a HOCM patient or AS patient, one of the biggest important things, especially for HOCM patients, which is dynamic LVOT obstruction, if they become hypotensive on the wards, the key thing is to make sure you fill them with fluid. It's much more important to fill them with fluid. That dilates the ventricle and actually opens up the left ventricular outflow tract, reducing the obstruction. That does not work as much for aortic stenosis. On the other hand, GTN, which is often used in these cardiac patients, if you give that to a HOCM patient, it reduces your preload. You get a smaller ventricle and you get a smaller LVOT. So it worsens your LVOT gradient. It worsens aortic stenosis, and so it's what we call a relative contraindication in severe aortic stenosis, but it is certainly an absolute contraindication in these HOCM patients in terms of your learning points and things that might come up for the exam. The other thing is these are very high-risk patients. In terms of cardiology patients, These are probably the highest rates of death on waiting lists of any patient for cardiology or cardiothoracic surgery. They come in with heart failure. They can get into big trouble. If you get hypotensive with them, so for a perioperative medicine physician, severe aortic stenosis, it's really important that we advise the anaesthetists to keep their blood pressure up, because if they become hypotensive at any stage for HOCM or aortic stenosis, they can spiral to the point that our usual medications, being noradrenaline, milrinone, dobutamine, they don't work in these patients because it's a outflow tract obstruction and it's almost impossible to get them out of it. If it's HOCM, you load them with fluids. But it's really important on an induction, when you peripherally vasodilate with your muscle relaxants in that perioperative space, it's really important that they keep the blood pressure up throughout that induction and don't allow them to peripherally vasodilate and drop their blood pressure. It's really important that everyone understands that when they come in, when they're breathless, these are the highest risk patients. We have a number of patients go into a valve crisis or a spiral every year. People die on waiting lists every year. And if you looked at, of all cardiology procedures or cardiothoracic procedures, treatment of aortic valve stenosis is the biggest procedure in terms of years of life gained of any procedure. So it says that the procedure works, but on the other hand, a lot of these people die, and it's worse than most cancers. There's very few cancers that have a 50% mortality rate at 2 years when you get it, that are as common as severe aortic stenosis. So just be aware of that, make sure patients are aware of that, get them treatment early. And there are lots of options. And I think especially for HOCM, making sure that you're not reassured by a moderate HOCM, because they might have just had a fluid bolus compared to someone who has severe HOCM. So there are a few sort of take-home messages regarding that, but it's a great case.
Thank you again, Prof. Roberts-Thomson. It was a fantastic case. I've certainly learned a lot. So for full details, listeners can refer to the article, which was titled 2-in-1 Combined Transcatheter Therapy for Hypertrophic Cardiomyopathy and Aortic Stenosis, which was published in the IHJ Cardiovascular Case Reports in 2020. The first author, Natalie Monterello, and second author, Prof. Ross Roberts-Thomson, who's joined us today. Thanks again.
Thanks, Stephen.
That was Associate Professor Stephen Bacchi bringing you another great episode of Pomegranate Case Report. We'd love to hear your feedback or suggested cases, so please send them through to podcast@racp.edu.au. Please do a trainee a favour and tell them about the Pomegranate podcast from the RACP. It's easy to stay up to date with the latest releases by subscribing through Apple Podcasts, Spotify, Castbox or any other pod aggregator. For the late adopters, there's even an email alerts list you can sign up to at our website racp.edu.au/podcast. I do want to give a shout out to staff members Adoni Patrikios and Abhilash Vajpayee for helping improve the user experience of those pages. You can no longer miss the Add to My CPD button at the top of each episode blurb, which takes you to a pre-filled entry form. Keep an eye out for an upcoming filtering tool that will let you search episodes by specialty or professional domain. Another great resource, this time at elearning.racp.eu.au, is the College Learning Series. These lectures are written around the basic training curricula, and there are 25 already up there listed under cardiology. Just next to the CLS there's another video library called Medflix, with more advanced or diverse content. This podcast was recorded on the coastal lands of the Kaurna people in Adelaide and of the Gadigal clans on Sydney Harbour. I pay respect to their elders past, present and in training. I'm Mick Cavazzini. Thanks for listening.